Ma'am. Hello.
Yes, ma'am, we can hear you.
Okay, okay. Can I start, ma'am?
Yes, ma'am.
Hello.
Yes, ma'am, we can hear you, ma'am.
Can I start, my class?
Yes, ma'am, we can start the class.
Okay. Okay. Okay, now we'll be discussing about infective endocarditis. Okay. Okay. Now, first we'll see the first we'll see the definition of infective endocarditis. Okay. Infective endocarditis will be most important topic for the UG. Okay. You'll see you'll get many questions from this topic. You'll get in entrance also it will be more very important topic for you. First we'll see the definition of infective endocarditis. Infective endocarditis is nothing but it's a microbial infection of the endothelial surface of the heart or the intracardiac device or any iatrogenic foreign bodies like prosthetic device. The infective endocarditis typically involves the heart valves. Issue more
Ma'am, we
common
can't
is
see the slides.
oh,
It's
one
showing
second.
charging.
Okay, okay. Sorry. Now,
Yes, ma'am, we can see now.
okay. Now, now can you
Yeah,
Yes,
able
ma'am.
to
ma'am.
see now?
Ma'am, can
Okay,
you
can I
make the
start?
screen in landscape mode, like rotate the screen? The font will be
Okay,
more,
okay, okay,
or in slideshow mode.
okay. Sorry.
Yes, ma'am, better. Thank you, ma'am.
Okay. Okay, ma'am. Okay, shall we start, ma'am?
Yes, ma'am.
Okay, I'll start from the beginning. Okay. Infective endocarditis. Myself is Dr. Madhurima. I'm postgraduate from M5, IAM. Okay. Okay. First, we'll see the definition of infective endocarditis. Okay. The definition will be infective endocarditis is nothing but the microbial infection of endothelial surface of the heart or the intracardiac device or any iatrogenic foreign bodies like prosthetic device. Typically, the infective endocarditis will involve heart valves. The most common will be mitral regurgitation. Uh, Apart from the heart valves, it may also involve other heart structures like cardiac tendinae and other sites of shunting and other neural lesions. When coming to the vascular part, if the infection involves the vascular shunt, that would be called as infective endarteritis. Next, the most common etiological agents when we see the first one will be streptococci. In the streptococci, viridian streptococci will about 30 to 40%. Other streptococci is about 15 to 25%. Next it will be enterococci, coagulase positive organisms and coagulase negative organisms. And gram-negative aerobic bacilli. The fungi will contain about 2 to 4%. Staphylococci is about 20 to 35%. These are the most common etiological agents responsible for causing infective endocarditis. Next, what are the predisposing conditions for causing infective endocarditis? The most common will be valvular lesion. When we see the valvular lesion, the most common will be mitral regurgitation. It is followed by aortic regurgitation. Then will be itic stenosis, followed by mitral stenosis. This will be the order of getting valvular lesions more prone for infective endocarditis. Apart from the valvular lesions, the people who are having prosthetic valve will be more prone for getting infective endocarditis. Some people will be having congenital heart disease. They are also more prone for having infective endocarditis. When we see an IV drug abuse, that in heart, it involves mostly right-sided valves will get involved in infective endocarditis. The most common will be tricuspid valve. And also the people who are having intracardiac devices also will be more prone for getting infective endocarditis. Next, we'll see the classification of infective endocarditis. We'll classify the infective endocarditis into native valve endocarditis, prosthetic valve infective endocarditis, IV drug abuse infective endocarditis, and nosocomial infective endocarditis. It is one type of classification. Other type of classification will be sorry, divide according to the duration of infection. We will divide it into acute and subacute infection. First, we'll see the organisms responsible for getting native valve infective endocarditis. Native valve infective endocarditis, the organism responsible is Streptococci viridans, Staphylococci, and Hayseck organism. The expansion of Hayseck organisms will be H for Haemophilus, A for Acinetobacterium, C for Cardiobacterium, and E for Eichinella, and K for Klebsiella. When coming to the prosthetic valve infective endocarditis, people who have done surgery within 1 year of 1 year, more from they're having coagulase negative staphylococcus, diphtheroids, and staphylococcus aureus. After 1 year of surgery, the organisms will be almost similar to the native valve infective endocarditis. Then, in IV drug abuse patients, more right side heart involvement will be more. In that also, tricuspid valve involvement will be more. The organisms when we see in the right IV drug abuse patients, the most common organism will be methicillin-resistant Staphylococcus aureus, Pseudomonas aeruginosa, Candida, Lactobacillus. In nosocomial, that is the healthcare acquired infections include Staphylococcus aureus, Enterococci, Pseudomonas, and Candida species. These are the common organisms responsible for getting infective endocarditis. Next, we're coming to the pathogenesis of the infective endocarditis. Initially, whenever our endothelium in the heart gets damaged, our body tries to repair any damage. So, a fibrin-rich clot will be formed in the heart valves. So, after the fibrin-rich clot formation, whenever we get any infection like any dental abscess, so sorry, the bacteria enters to the platelet-rich clot region, thereby othering to that clot formation. So, in transient bacteremia condition, that bacteria binds to the clot. So, thereby development of vegetation. After the development of the vegetation, this it may lead to the either direct spread of the vegetation, spreading to the either myocardium, pericardium, causing septicemia, or the vegetation may get embolied to the peripheral organs like eyes and peripheral vascular areas, or the immune complexes may get deposited in the either in the kidney or causing glomerulonephritis. Mostly the pathogenesis, after the pathogenesis, we'll see the clinical features of infective endocarditis. The vegetations will lead to embolization, thereby forming the most importantly skin lesions. First, we'll see the general symptoms include malaise, clubbing. The cardiac features will get murmurs, heart failures, arthralgia, pyrexia. Most common symptom will be pyrexia. The patient commonly presents to us with fever. The skin lesions will be olar nodes, splinter hemorrhages, JMA lesions, petechiae. I'll show the pictures of these images in the further slides. In eyes, we'll see rot spots, conjunctival splinter hemorrhages, splenomegaly, neurologically we get cerebral emboli, mycotic aneurysm, and hematuria. So the most common symptom patients present to us with fever. Okay. we will see the morphology of the vegetation. In the infective endocarditis, the vegetation will be friable, bulky vegetation containing fibrate, inflammatory cells, and microbes. The most common valves involved are aortic and mitral valves. In IV drug abuses, the right-sided valves are more commonly involved. In this image, you can see the friable, bulky vegetation. It contains fibrate, inflammatory cells, and microbes. Okay. The most important criteria in infective endocarditis, you should remember, is the clinical Duke's criteria. I'll further discuss in the coming slides. I'll discuss about the Duke's criteria. The investigations we usually do is the blood culture, polymerase chain reaction. The echocardiography will be the most important infection to detecting infective endocarditis. We'll see the vegetation in transthoracic echocardiogram detects vegetation in about 65 to 80% of patients, but the esophageal echocardiogram detects with more than 90% of patients with definitive endocarditis. The transesophageal echocardiogram will be more specific investigation for this infective endocarditis. Then we'll learn about the Duke's criteria for diagnosing infective endocarditis. The Duke's will say in the diagnosis of infective endocarditis is definite if the following criteria is fulfilled. The criteria will be two major. We'll divide it into major criteria and minor criteria. The major criteria, it in, so to say it as a definitive endocarditis, two major criteria should be there, or one major and three minor criteria should be there, or five minor criteria should be there. Should be there. Then, if all these five features are there, then we'll consider it as a definitive endocarditis. If only one major and one minor or three minor is there, we'll say it as possible endocarditis. Okay. Then we learn about the Duke's criteria. It's a table showing what are the major criteria of major Duke's criteria to say it as an infective endocarditis. Okay, the major criteria says that the blood culture should be positive. For typical organisms include Streptococcus Streptococcus galeoticus, basic group organisms, Staph aureus, or community acquired enterococci. So, blood culture should become positive for these organisms, or if the blood culture is persistently positive, it means that the recovery of an organism consistent with infective endocarditis from the blood culture which are drawn more than 12 hours apart, or all of three of a majority of more than four separate blood cultures, with the first and last drawn at least 1 hour apart. If the organism is like Coxiella burnetii, a single positive blood culture result is enough. Or IgG antibody titer should be more than 1 is to 800. So first criteria will be the blood cultures. First criteria we will see about blood cultures. Then cardiographic involvement. In the echocardiography, what we will see is uh, to say it as infective endocarditis. In echocardiography, we will see an oscillating intracardiac mass and valve or the supporting structures. And on the part of regurgitant discs, the absence of alternative anatomic explanations. Okay, in the echocardiogram, we should see the vegetation, or if the prosthetic valve is there, with a new partial dehiscence of prosthetic valve, or any new abscess, or any new valvular regurgitation. If we in echocardiogram we see any findings, we suspect infective endocarditis. So the major criteria will be first one will be positive blood culture. For typical microorganisms, it differs for typical and atypical microorganisms like Coxiella burnetii. The first point to remember is the blood culture should be positive. Next is the echocardiographic involvement. We should be there. In the echocardiogram, we should see the vegetation as an intracardiac oscillating mass, or any abscess should be there, or any partial. If the prosthetic wall is there, if the partial lesion should be there. Then new onset valvular regurgitation. Uh, how to find out any change in the pre-existing murmur. So, remember about major criteria. First thing is to the positive blood culture, then evidence of echocardiographic involvement. Okay. Next, we'll see about minor criteria. The minor criteria had already discovered about the predisposing conditions. If any of the predisposing conditions are present, we'll take it as a minor criteria. Then fever implies more than 38 degrees centigrade or more than 100.4 degrees Fahrenheit. Then vascular phenomena. The vascular phenomenon, it includes vascular phenomena occurs due to the embolization of the vegetation. I had already discussed in the pathogenesis how vegetation is formed. After the formation of the vegetation, it gets embolization to the peripheral vessels, so that forming the vascular phenomenon. If the vegetation gets embolized to the arteries, we make it infarct. Due to the embolization of the artery, we make it mycotic aneurysm. Mycotic aneurysm is nothing but due to the infection of the vessels, the blood vessels will get dilated. It is a false term. It's not a fungal organ. Fungal. It's not caused by fungus. It is due to bacterial infection of the blood vessel. Uh, then intracranial hemorrhages may occur. Conjunctival hemorrhages may occur. Janeway lesions. Janeway lesions. I will show the pictures in the further slides. These are the vascular phenomena. Then coming to the immunological phenomenon. Immunological phenomenon is due to the deposition of the antigen antibody complexes, thereby forming the glomerulonephritis, Euler's nodes, rod spots, rheumatoid factor. Euler's nodes and rod spots. Euler's nodes occurs on the palms. I'll show the pictures in the further slides. Rod spots occurs in the eye. Next, microbiological evidence. Microbiological evidence implies that positive blood culture, but not meeting the major criteria. I had already discussed the major criteria to get positive in typical and atypical, as noted previously. So, if the criteria does not meet the major criteria, we will take it as a minor criteria. Then, serological evidence of active infection with an organism consistent with infective endocarditis. So, this will be the minor criteria. So, in the major criteria, we had discussed about the blood culture and echocardiographic evidence. So, coming to the minor criteria, five most important will be the predisposing condition should be there. The fever should be more than 38 degrees centigrade, and vascular phenomenon, immunological phenomenon, the microbiological evidence. If it is not sufficient to take it as a major criteria, we take it as a minor criteria. Okay. So, if to say it as a definitive endocarditis, I'm again revising this. Two major should be positive, or one major and three minor should be there, and five minor should be there. Okay. If only one major and one minor is there, or three minor, we'll take it as a possible endocarditis. Okay, we'll do modified risk criteria. Almost you'll get questions in every exam, so I kindly request to revise these slides further later. So I told you about rod spots. It's an immunological phenomenon due to the deposition of immune complexes in the eye. We'll get these white areas. These called as rod spots. Then it is an OLS node. It is a painful erythematous nodular lesions. We will get in the tip of the fingers. It is called Oler nodes. Next will be Janeway's lesions. Janeway's lesions typically occurs in the palms and the soles. Okay, then these are splinter hemorrhages in the nails. These are non-specific, non-blanching, linear reddish brown lesions found on the nail bed. Usually do not extend the entire length of the nails. So these are the most important images to be remembered. So the infective endocarditis mainly consists of Oler nodes, rod spots, Janeway's lesions, and splinter hemorrhages. These lesions are mostly due to either immunological phenomenon or vascular phenomenon that occurs due to the embolization of the vegetations or due to immune complex formation. Then the subconjunctival hemorrhages also occurs in infective endocarditis. If the vegetation got embolized and it deposited in the retinal arteries, we will get septic retinal embolus. Next, these are the symptoms. There is a picture showing you the symptoms of infective endocarditis. Uh, the symptoms it's showing the persistent fever, constitutional symptoms, any new signs of valvular dysfunction, heart failure, embolic stroke, and peripheral arterial embolization. We will get varying murmurs. In the heart, we will get conduction disorders, cardiac failures, hematuria, petechial rashes, we will get splenomegaly. There is an image showing all the symptoms of the infective endocarditis up from tip to head. So, so in the from head to toe, if you see, you get the ventilation got emboli, you get cerebral emboli. Ce- Sorry, cerebral infarct or hemorrhages can occur. In the eye, you can get hot spot, petechial hemorrhages, you can get splenomegaly, systemic emboli, digital clubbing. You get clubbing in infective endocarditis, splinter hemorrhages, loss of pulses due to the embolization of the vegetation, petechial rashes, ovular nodes, conduction disorders also you can next. Okay, we had seen the criteria for the diagnosis of endocarditis. We had seen the lesions occurring in infective endocarditis due to the embolization of the vegetation, and then we'll discuss about the treatment of infective endocarditis. According to the current organism responsible for infective endocarditis, according to the organism, we should decide the antibiotic. If the organism is a penicillin streptococci, penicillin G ceftriaxone. No need to remember the doses. Just remember the antibiotics should be given in the specific organism. If it is a penicillin susceptible streptococci, we will give penicillin, ceftriaxone, vancomycin, and if the organism is relatively penicillin resistant, we will give penicillin G or ceftriaxone, plus we will give gentamicin and or vancomycin also we can give for 4 weeks. The moderately penicillin resistant streptococci, we will give gentamicin as a single dose or divided into equal doses. When organism will prefer the antibiotic. In enterococci, we will give the penicillin plus gentamicin or ampicillin plus gentamicin, vancomycin plus gentamicin. This is the combination we can use in enterococci, ampicillin plus ceftriaxone. These are the tables taken from the Harrison. Okay. Mixing susceptible staphylococcus infecting the native walls, we will prefer methicillin, oxacillin, cefazolin, or vancomycin. If the organism is methicillin resistant, we will do vancomycin. According to the susceptibility, we will change the antibiotic. If the methicillin susceptible staphylococcus is affecting the infectic valves, then we will give methicillin or oxacillin or fluticillin with the combination of gentamicin. If the MRSA is infecting the prosthetic valve, we will vancomycin plus gentamicin plus rifampicin. Next, if the organisms are haystack organisms, we will prefer ceftriaxone 2 gram IVOD, ampicillin or sulbactam. If the organism is a Coxiella burnetii, we will give doxycycline plus hydrochloride. Next, for Bartonella, we will give doxycycline. Next, for whom we should prefer infective endocarditis. For high-risk cardiac patients like so most people who are more prone for getting infected endocarditis, like if the patients are having the valvular lesion or they are more prone, they are immunocompromised, then we'll give prophylaxis for the patients. The standard regimen for giving prophylaxis infective endocarditis, standard regimen will be amoxicillin 2 gram per hour. If they are going for any procedure, we'll give if they are giving for any surgical procedure, we'll give definitely prophylaxis. Antibiotic regimens are standard regimens amoxicillin. Inability to take oral medications like unconscious patients or on sedation, we can use ampicillin. If the patients are allergic to penicillin, we use clarithromycin, clindamycin. If the patients are penicillin allergic and inability to take oral medication, so you give IV medications like ceftriaxone to indomycin. Next, what are the high risk cardiac lesions for which endocarditis prophylaxis advised? Before doing any procedure, uh, patients who are more prone for getting infective endocarditis are the patients who are having any prosthetic valve, any prior endocarditis, or they are having any undefined congenital heart diseases, including the palliation or the condition, or their completely repaired congenital heart disease during the 6 months after repair, incomplete congenital heart diseases with residual adjacent to prosthetic material, or valvulopathy after cardiac amnion. These patients that their high risk cardiac agents for cardiac agents for which we will do endocarditis prophylaxis before any dental procedure because they are more prone for getting infected endocarditis. Even the transient bacteremia also the bacteria gets lodged into the vegetation, causing the clinical features of the endocarditis. Then, who will need cardiac surgical treatment for endocarditis patient? Uh, Surgery required for optimal outcome are native valve or prosthetic valve endocarditis, or the moderate to severe congestive heart failure or shock due to valvular dysfunction. Any if the valve get perivalvular extension, it abscess fistula, if the persistent bacteremia without an extracardiac cause, and lack of antibiotic therapy, and partially there is unstable prosthetic valve. So there is a table showing the surgical treatment who the patients needed what the patients needed surgical intervention. So the most important to remember in infective endocarditis will be there will be a formation of a vegetation in the heart due to the bacteremia. Initially, I'll again revise the main topics. Okay. You should mainly remember the etiological agents responsible for the infective endocarditis. Then the predisposing lesions. If it is only valvular lesions and IV drug abuses, these are the more prone for getting infective endocarditis. Then how we will be classifying the infective endocarditis according to the etiology and according to the duration we will classify. Then we should mainly remember the pathogenesis. The pathogenesis mainly occurs due to the formation of due to the injury of the endocardium, thereby forming a fibrin-rich platelet formation. It leads to the a non-bacterial thrombotic endocarditis. Thereby, after this stage, if the patient undergoes any dental procedure or any surgical procedure, the bacteria enters into our body. It then binds to the clot, thereby forming a vegetation. The formation of a vegetation will be the most important. Then leads to the vegetation may lead to direct spread, or it may get embolized, or the immune complexes will be formed. These are the most important pathogens are responsible for the development of the clinical features. After the formation of the vegetation after getting embolization we get the rods, most vascular and immunological phenomena. I had already previously discussed that. Then it is very important to remember about the Duke's criteria. Duke's criteria it will have major criteria, minor criteria. I have discussed about the possible endocarditis and definitive endocarditis. Rods, the main points to be remembered will be region get effect, where we will get rod spots, Ohlers nodes, Janeway's lesions, splinter hemorrhages, and subcontinuous hemorrhages. These are the clinical features of infective endocarditis. Then the antibiotics to be given after getting the results of the culture according to the organism will give the respective antibiotics. Okay, thank you. Hello.
Thank you, ma'am.